Hi, I'm Rujula Upadhaye and I'm going to talk about Staphylococcus aureus infection. Staphylococcus aureus is a gram-positive cocci arranged in clusters as the daughter cells fail to separate after division. They are normally present as commensal bacteria on our body surfaces, but they can be pathogenic as they enter through minor abrasions and wounds. They can invade deeper into the tissues with the help of enzymes like hyaluronidase, protease, and lipase. With the help of coagulase, it forms a fibrin clot around itself and hide from the host immunity. And when the right time comes, it can easily dissolve the clot with the help of staphylokinase and then continue its invasion. Pretty cool, right? Yeah. One more cool thing it does, it evades the host immunity very efficiently. So normally any antibody has a fixed portion and a variable portion, right? So the variable portion binds to the antigen so that the macrophage can recognize it, engulf and destroy it. But Staph is a very clever bacteria. It has a capsule which prevents opsonization and a protein A on its membrane which does not bind to the variable portion but binds to the fixed portion, which looks like this, which is completely opposite to what normally looks. Thus, the macrophage cannot identify it and it easily escapes the immunity. Thus, this Staphylococcal aureus infections can be normally seen in immunocompromised individuals like patients of diabetes, HIV, or patients on hemodialysis, etc. The most common infections caused by Staphylococcus aureus are the skin infections. It can enter into the hair follicle, causing folliculitis. It can go deeper into the subcute tissue, leading to cellulitis. If pus accumulates in the follicles, it can result in furuncles or boils. Infections around the nails is called as paronychia. On the face, you can see a characteristic lesion where there are red sores formed and they burst to form honeycombed crusts, which is called as impetigo. From the skin, it enters through the blood vessels, causing bacteremia, leading to sepsis. There can be central line associated infections. The most common cause of infective endocarditis is Staph aureus, which includes native as well as prosthetic valves. In intravenous drug users, it can also lead to thrombophlebitis. From the blood, it can also reach the respiratory tract, leading to pneumonia, empyema, pneumothorax, and the characteristic pneumatocoel in neonates, as you can see in the X-ray. It can infect the muscles, causing large abscesses, pyomyositis, septic arthritis, and osteomyelitis. Osteomyelitis in children affects generally the long bones, and in adults it usually affects the vertebrae. It can also reach up to the brain, causing meningitis and epidural abscess. Okay, so now we have learned about the infections caused by the Staphylococcus bacteria itself. But that's not it, guys. It can also release toxins and cause intoxications. So there can be a primary infection or foci in the body, and it can release toxins through the blood. It can cause intoxication anywhere in the body. So let's see what's the first intoxication. Staphylococcal scalded skin syndrome. Its initial infection is an impetigo or staph throat, and from there the toxins are released and it attacks a protein present in the skin called as the desmoglein 1. It is an adhesive protein, so if it is damaged, there is a split in the skin, as you can see, which results in blister formation. So if you scratch, large sheets of skin easily rips off. That is called as the Nikolsky skin. This disease is usually seen in newborns, which shows irritability, fatigue, chills, and rashes like this. Its milder form is called as pemphigus neonatorum, and when it involves systemic manifestations, it is called as the Ritter's syndrome. In adults, it has a more localized infection called as bullous impetigo. The other toxins like the toxin shock syndrome toxin and some enterotoxins are somewhat different. They are not normal antigens but super antigens. What are these super antigens? For that, let's see how antigens are presented normally. Okay, so imagine there's some antigen in the periphery, skin or anywhere in the body, and an antigen presenting cell picks it up and brings it to the lymph node. Okay, now in the lymph node there are a number of T cells circulating. Okay, now only that T cell will bind to this antigen, which has the T cell receptor specific to its antigen, and then only the clones of that T lymphocyte will be formed. But that's not the case with super antigens. Super antigens does not require the processing of these antigen presenting cells. It just binds laterally to the MHC class II and non-specifically to all the T cells which has this variable portion. So there is a massive T cell production which leads to a syndrome called as toxic shock syndrome. So there can be contaminated vaginal tampons, staph abscesses, etc., which can release toxins leading to this non-selective T cell proliferation, which will later then result in massive cytokine release, manifesting as fever, mucosal hyperemia, erythematous rashes, hypotension, and eventually leading to multi-system organ involvement. You can diagnose it by latex agglutination enzyme immunoassay and manage these patients by giving IV fluids. You can remove any foreign bodies like tampons which are causing the problem, and finally give antibiotics. Let's look at the last toxin, that is the enterotoxins, which cause food poisoning. It is a preformed toxin. The toxin is already formed in the food. It is usually seen in cooked food because it is heat stable. It can resist the heat, and it can also resist the gastric juice. So it is usually seen in processed meat, milk products, and bakery products. So how does it cause food poisoning? It directly affects the intestinal epithelium, prevents the reabsorption of water, and causes diarrhea. It can stimulate the vagus, which in turn activates the parasympathetic system and increases the motility of the stomach. It can also transmit the signal to the vomiting center in the brain and results in nausea and vomiting. So what are the investigations? ELISA, PCR, latex agglutination, with which we can diagnose. And you can manage the patient by giving just supportive treatment. There is no requirement of any antibiotics. Now this staph bacteria is a very notorious bacteria. It was actually a very good boy in 1940s, where around 90% of the infections were killed by a simple penicillin. But later on, it got carried away and developed resistance. The receptors present on the surface of the bacteria are called as penicillin binding proteins, which are modified so that the penicillin cannot bind to that protein and destroy the bacteria, leading to penicillin resistant species. Then we had to use nafcillin and cloxacillin like antibiotics to treat the methicillin sensitive ones. But later on, the bacteria got even more smarter and they developed resistance against methicillin as well, leading to methicillin resistant Staphylococcus aureus species, having the MEC-A gene, and we had to use vancomycin to treat it. So there can be two types of MRSA, the community associated and the hospital associated. The community associated is a more virulent and it causes invasive infections like necrotizing fasciitis. The hospital associated is comparatively less virulent, but it is multi-drug resistant. In 2002, the scientists also found out a Staphylococcus strain which is even resistant to vancomycin, which is called as the vancomycin intermediate or vancomycin resistant species having the VAN-A gene. They are rare for time being, but their incidence can rise in near future to an extent that we might not have any medicine to fight this mighty bacteria. Hence, it's imperative to take the safety measures. Have good face and hand hygiene. By now, you must have got the hang of it because of COVID-19. Don't share personal items. Clean bathroom and kitchen surfaces. And last but not the least, please take antibiotics only when they are needed, and when you do, take them as they are instructed. Thank you. Bye.